Okay, we're gonna continue on chapter 3, drug interactions. We're gonna look at page 64. So the first rotation that I did again was in the CCU, the cardiac care unit. So we're going to look at the chart of additive side effects, which is looking at QT prolongation. And so we have the column of risk, and then what should we do about it? What actions should we take, and what type of notes are written here? So then let's go over some of the types of medications that we're going to see that can cause QT prolongation and may have additive side effects. So we have the antiarrhythmics, the anti-infectives, antidepressants, antipsychotics, antiemetics, the oncology medications, and others, as we know. So in terms of the antiarrhythmics, we have the class 1A, class 1C, and the class 3. So we can look those up in the arrhythmias chapter. Under anti-infectives, we're thinking like hydroxychloroquine, which is an anti-malarial. We're also looking at the azole antifungals. We're looking at the macrolides and the quinolones. We're also looking at the antidepressants and the antipsychotics. So we're thinking like highest risk with SSRIs would be with citalopram and escitalopram. We also are looking at the tricyclic antidepressants. We have mirtazapine, trazodone, and venlafaxine. With the antipsychotics, in terms of first generation, we're looking at haloperidol and thioridazine. In terms of the second generation antipsychotics, highest risk is with ziprasidone. With the antiemetics, we're taking a look at ondansetron. And then with the other antiemetics, we're looking at promethazine, metoclopramide. We also have included here some oncology meds. So we're thinking leuprolide, and in the class of others, we have like donepezil, we have silostazol, hydroxyzine, loperamide, ranolazine, silofenicin, methadone, and tacrolimus. So what is the risk? So QT prolongation will increase the risk of torsades, and this is often a fatal arrhythmia. So this risk increases when we're using higher doses, when there are higher drug levels due to concurrent enzyme inhibition or inhibitors. So the risk increases with higher drug levels due to reduced drug clearance, such as when there is renal disease and liver disease. And the risk will increase with multiple QT prolonging drugs when those are used together. All right, let's take a look. The the last note of risk talks about QT prolongation in elderly patients, and it's defining elderly patients as in 60 years of age and older, as well as patients with cardiovascular disease, which includes patients who have arrhythmias, heart failure, and MI. So what types of things can be done about this? So with all of the QT prolonging drugs, we want to avoid and reduce the risk of torsades. So there's going to be 1, 2, 3, 4, 5 bullet points. The first bullet point says limit the use of the QT prolonging drugs. Select drugs with the lower QT risk, especially with patients that have arrhythmias in their history. Also, limit the use of QT prolonging drugs and select drugs with lower QT risk with patients who have cardiovascular disease or cardiovascular disease risk. There is a note here, exception. Amiodarone is the drug of choice to treat an arrhythmia in patients with heart failure. The second bullet point note says carefully dose the QT prolonging drugs and use lower doses, and again caution with use in elderly patients that are greater than 60 years of age. There's a few subsets of notes here, like do not exceed citalopram dosing of 40 milligrams per day, and do not exceed 20 milligrams per day in elderly patients greater than 60 years of age. Also, these dosings apply if the patient would have liver disease and with enzyme inhibitors that would decrease clearance. Also, don't exceed S-citalopram at a dose of 20 milligrams a day, and the dose would be 10 milligrams in an elderly patient that's 60 years of age or older. Within this same subset, it says when using SSRIs like sertraline, sertraline would be actually the safest in cardiovascular disease patients. Moving on to the third bullet point, avoid concurrent QT prolonging drugs if it's possible. Fourth bullet point says avoid use of inhibitors that would actually block a QT prolonging drug's metabolism. And then the fifth bullet point says do not use droperidol. For inpatients, let's see. Droperidol is going to be injection only, and it does have restricted use due to QT prolongation risk. So that one is typically something that we will make a note about, and we'll go look that up in the arrhythmia chapter for more information. All right, so moving on, page 64, we have next topic of CNS depression. So there are many drugs and many drug classes that can cause CNS depression. So the common ones that we know are opioids, skeletal muscle relaxants, anti-epileptic drugs, benzos, barbiturates, hypnotics. Also, we have antidepressants such as mirtazapine and trazodone. We have antihypertensives like propranolol and clonidine. We also have dronabinol. We have sedating antihistamines. We have cough syrups with an antihistamine or an opioid. And we also have some NSAIDs that can cause CNS depression. Highest risk for fatality when used in combination, like opioid plus benzo, or opioid plus another CNS depressant. So looking at the risk column, CNS depressant effects like somnolence, dizziness, confusion, cognitive impairment, altered consciousness, delirium, gait, instability, imbalance, risk of falls, accidents, including motor vehicle accidents. Benzos are a drug of abuse. They are often prescribed inappropriately for anxiety or insomnia, adding unnecessary risk of CNS depression. Benzos are appropriate for status epilepticus, alcohol withdrawal, as an antidote for stimulant overdose prior to medical procedures, in acute high anxiety situations, and for anticipatory emesis with chemotherapy. Opioids, due to the risks of abuse, dependence, and addiction, reserved for severe pain that is not responsive to other measures. So what types of actions should happen here? So again, provide counseling, like don't use with alcohol, do not operate a car or other vehicle or machine, can increase risk of fall and confusion. Monitor for sedation, monitor for slow and shallow breathing, monitor for shortness of breath, avoid combining CNS depressants when possible. Suggest alternatives for anxiety. Suggest maybe using an SSRI or an SNRI. Suggest alternatives for insomnia. Lifestyle treatments would be preferred. Suggest alternatives for pain. And for pain, consider Tylenol, NSAIDs, and antidepressants instead of opiates. Alright, now we're looking at actions and notes about opioids specifically. So we have 1, 2, 3, 4, 5 bullet points for opioids and notes and actions. So the first bullet point states, do not use in combo with benzos. Use of other CNS depressants, including alcohol, have a high risk of fatality with opioids. The second bullet point for opioids. Extended release formulations have additional risk. Several become shorter acting when taken with alcohol, which increases the risk of fatality. Recommend naloxone for at-risk patients, including use of high doses, rapid dose increase, or reduced clearance. For example, renal impairment with morphine. 1, 2, 3. Bullet point 4. Avoid codeine if pharmacogenomic profile is unknown. The highest risk is with the cytochrome 2D6 ultra-metabolizers, which we talked about. Bullet point 5. Reference back to the cytochrome 3A4 and 2D6 interaction information that was previously discussed. And that is the end of page 64.